Hi, my name is Ben Sommers. I'm an assistant professor of health policy and economics at the Harvard School of Public Health and also a primary care physician at Brigham and Women's Hospital here in Boston. The two main ways that health reform will expand insurance coverage is first by providing tax credits for subsidies to middle-income families applying for insurance through a health insurance exchange, and for lower-income families who will become eligible for expanded Medicaid coverage. So the health insurance exchanges right now are largely existing in a conceptual form. The actual shape that they'll take is going to be determined over the next couple of years by each state that has some flexibility to decide for itself. But overall, the idea of an exchange is that it's a marketplace, often online or an internet-based market, that allows insurers and customers who are either small employers or individuals who are looking for coverage to come together, look at the options, and then select the coverage that's best for them. The main difference with the health insurance exchange is that the state plays a much more active role in the insurance market. Instead of this being transactions that occur by private customers and private insurance companies, there's a central government-run exchange that is providing the format for these interactions. They'll set some of the rules of what kinds of policies can be offered, what kinds of premiums are going to be allowed, the essential benefits that will be covered, and then through the government oversight, the insurance exchanges will hopefully both improve the quality of coverage and the administrative efficiency of the process. Right, so the 400% of federal poverty cutoff is the upper limit of the people who will be eligible for subsidies in purchasing insurance through the exchanges. For a single adult, that's about $42,000 a year, and for a family of four, it's just under $90,000 a year. So the mandate itself is really a penalty through tax returns. So that if somebody, when they're filing their federal tax return, has not had insurance coverage for the whole year, then they're subject to an additional tax penalty. And this will be scaled in over the first couple of years of the health reform. But when it hits the peak, the fee will be about $700 for an individual or 2.5% of their income, whichever is higher, per person who doesn't have coverage. So one of the key features of expanding coverage through health reform is going to be the significant expansion in Medicaid eligibility. The numbers of people who will be affected by this vary depending on what estimates you look at. The Congressional Budget Office thinks that it will be about 16 million new enrolled adults in Medicaid by 2019. The Centers for Medicare and Medicaid Services estimated about 18 million. But these numbers are really imprecise because they require a lot of assumptions about so many different complicated factors. What's going to happen in the economy, what's going to happen in the private insurance market, and so it's very difficult to be exactly sure how many people will end up in the program. And one of the key factors that will determine the size of this expansion is how many of those who are eligible actually take up the coverage and join the program. So the health reform legislation introduces kind of a sliding scale over the first 10 years of reform. Initially, the federal government is going to pay 100% of the cost of all new enrollees under the Medicaid expansion. This number gradually goes down to 90% in 2020 and remains at that level thereafter. So states after about 10 years will be on the hook for 10% of the cost of the expanded Medicaid coverage. The key point of our paper is that eligibility for a program doesn't always turn into real health coverage. Our study looks at data from the last 3 years from the Census Bureau, and we looked at eligible adults who are currently eligible for Medicaid coverage who have no other form of insurance. And what we found was that in this group, 60% are currently participating in Medicaid, which means that 40% are uninsured, even though they're eligible for a free public program. And this number varies widely across states. It's in the mid-40s in several states. It's as high as 80% in Massachusetts. And what this tells us is that it's not enough to expand eligibility on paper. To really improve healthcare access for those who are currently uninsured, states are going to need to exert effort to identify, enroll, and then keep enrolled eligible adults in their programs. And the fundamental point of the paper is that if states don't take this effort or states don't find effective ways to do this, a lot of the potential gains in coverage won't happen. So if someone who's eligible for coverage has something catastrophic happen and then ends up needing medical care, they are eligible for retroactive coverage, and that will cover the expenses of that acute episode, and then they'll be enrolled for the coming 6 to 12 months. The issue really in terms of quality of healthcare and healthcare access comes more on the preventive side. That somebody who may be eligible but not actually enrolled in a program is much less likely to visit a doctor, much less likely to get ongoing care for chronic diseases, routine screening for chronic diseases and cancer. So we know that there's a real harmful health effect of being without coverage, even if in the case of an emergency that person would end up enrolled in a program. So because of that, there's a real incentive, if we're worrying about public health, to get people enrolled at the outset and not wait until something catastrophic happens. So Massachusetts had the highest participation rate in Medicaid of any of the states in our study at 80%. And the first thing to recognize is that Massachusetts has a fundamentally different healthcare system than most other states because of the comprehensive health reform that occurred in 2005 and 2006. So first off, we have an individual mandate in Massachusetts. Everyone is required to have health coverage. There's also a health insurance exchange that's already in place called the Connector, and this works closely with MassHealth, which is the name of our Medicaid program here in the state. The two programs together have a single application process. So if anyone wants to apply for insurance coverage in our state, they simply fill out an application that goes to the government, and the government then figures out which program they're actually appropriate for. So individuals don't have to sort through that for themselves to begin with. Other features that are really important is that Massachusetts has made an infrastructure investment, and the political leadership of the state is really behind making this expansion work. And so with that kind of backing, the state continues to find effective ways to enroll eligible people and keep them in the program.